Hello. So before we go into the X-ray images, we will analyze important things about osteoarthritis. Osteoarthritis most commonly affects the hip joints, but it can affect any synovial joint. But the hip joint and the knee joint are, I would say, the two most commonly affected joints, and any statistic you will see that the hip joint is the most affected. So osteoarthritis, in order to explain it, it is important to remember the phrase that it is a wear and tear arthritis. So basically, over the years, as we use our joints, so a lot of pressure is put on our hips and knees, but it can be put on any joint. Over years and decades of working and of trauma to the joint, eventually we develop osteoarthritis. So, for example, if we would live all 100 years, if every one of us would live 100 years, we would all have definitely osteoarthritis in some of our joints. So basically, old age is a big predisposing factor for osteoarthritis. Also, any mechanical damage and trauma to the joint, especially joint fractures, also bad alignment after fracture healing, or bad alignment due to bad development of bones, will all predispose for earlier osteoarthritis in even younger people. So here we will explain some of the features that we actually see on X-ray, but we will explain how they happen and how actually it comes to osteoarthritis. So this is a normal hip joint. The hip joint is a ball and socket joint, where the ball is the humeral head and the socket the acetabulum bone, and they are lined with hyaline cartilage. This hyaline cartilage here in blue is actually very thin, a few millimeters, and it has no nerves, and we can have no pain in our cartilage. But once the cartilage gets eroded and the bone underneath the cartilage, that is called subchondral bone, is exposed, there will be pain. So, how does it come to arthritis? First of all, over the years, with mechanical damage, here we see the joint simplified. We see that this would be the articular cartilage on both surfaces. We see how this joint space between the two joint surfaces is equal, and this joint space is filled with synovial fluid. Over the time, as we have mechanical damage, for example, the bone is aligned bad and this part is pushing more often this part, and it should be pushing the same on all of this, on the whole surface, but because the bone is badly aligned due to bad development of bone, a bad fracture that has healed wrong, the pressure could be greater here, and this is the first site where the cartilage will be damaged. So once the cartilage has a site of damage, first it will be there, then after some time the cartilage will thin out on other places. So over time the soft cartilage that is only a few millimeters thick thins out over the time, over years, and it is eliminated. It is damaged and deconstructed in the joint. So on X-rays we cannot see cartilage, but we see the joint space, and in the joint space we need to imagine that there is cartilage. We see only bone and the joint space that has this width to it. So once the cartilage is damaged, one important thing that we start seeing on X-ray, so the first important thing is joint space narrowing. So this joint space, as you see here, there is destruction, and the joint space got narrower. It got narrower because the cartilage is destroyed and the bones got closer together. So the narrowing of the joint space shows us that there is damage to cartilage. Also, when there is damage to cartilage, the joint loses a part of its stability. And because of loss of stability, the joint tries to adjust, and it tries to adjust in a way that first it starts as bone is rubbing bone, cartilage is destroyed, bone is rubbing bone, and this process is creating dense subchondral bone. So this bone that is underneath, that was underneath the destroyed cartilage, and now only bone is there, is called subchondral bone because it is usually under cartilage. Subchondral meaning under cartilage. It gets thickened and it becomes dense subchondral bone, and this dense subchondral bone, it is actually becoming dense because now the bone is rubbing against bone, the pressure is on the bone, and it tries to shield itself by getting thicker. It is also called eburnated bone. Eburned is actually in Latin ivory because it is so white and dense. It reminded someone of ivory, so they call it eburnated bone. That is also something we can see on X-ray, that the bone is more dense, it picks up more X-rays, and the cartilage can't be seen because it is not dense normally. Then also the joint tries to adapt to the mechanical instability or the disrupted biomechanic through forming of osteophytes. Osteophytes. So these small bony protrusions, small bony appendices that are forming in the joint and trying to somehow stabilize joint. They are created because the joint has disrupted biomechanics, and also because of this damage, the damage of the cartilage and the damage of the bone, we will have chronic synovitis, and this chronic synovial inflammation that is happening will also start pushing the cells in the synovium to produce osteophytes. Then, as this destruction is developing over the years, we can have also the subchondral bone can be even thicker. The joint space narrowing can be very severe and can lead to joint fusion, or joint fusion is also called ankylosis. Here we have also the formation of bone cysts. So in this bone that is rubbing against bone, we always have microfractures, and the synovial fluid that is present pushes into these microfractures, and over time it erodes the bone so that bone cysts form, and they are called actually subchondral bone cysts because they are actually underneath the space where the cartilage was, so they are called subchondral bone cysts or bone cysts. They are actually fluid, synovial fluid accumulations that have a fibrous wall, and they are a sign of severe degeneration. Also, in the clinical, when we analyze these patients, so in these first stages, where we have only cartilage damage, there will be pain. Once the cartilage is off, there will be pain. Also for the movement where the patient feels the pain, he will also limit those movements. But once the joint is somewhere between where we see joint narrowing, and especially or many osteophytes, we can have loss of movement. So movement will be blockaded, or there will be contracture and so on. So these are the important things to know before analyzing the X-ray, because the X-ray analysis will be easier to understand.
Hello. So now we will look at some X-rays, some X-ray examples of osteoarthritis, and exactly of the osteoarthritis of the hip joint. So if we look here, basically the pelvis with the right and the left hip joint, the important thing to note is that, of course, always compare each side, so there needs to be symmetry. And of course, this joint looks deformed. There is no big thinking around it. It is definitely looking deformed to even someone who never looked at an X-ray. This joint looks normal, but there are changes. So if we see here, we will go from this side that looks relatively good, but it is not good. Here we can see that this is the bone, the end of the bone. So after the end of the bone here should be cartilage, and we can see that we here see some joint space, but we can see here that we don't see joint space, and that this bony surface of the head of the femur and the acetabulum, they are touching, and they are not smooth like this, they are deformed. We can also see here that there is thickening of the subchondral bone, so the bone that is underneath the cartilage, and also some formation of osteophytes. So this is also some degree, a moderate degree of Cox arthrosis or osteoarthrosis of the right hip joint. But here we have a severe case, so the left side is definitely more affected, and we can see that there is obliteration of the joint. We can differentiate out the joint space. There is a lot of new bone, and there are these small, you can appreciate them around spaces that are also subchondrally located. So these are these bone cysts. The joint space has narrowed, the subchondral bone has thickened, and this joint, if you would examine this clinically, the patient could only do a very limited amount of movement and probably have severe pain in the joint. And also we can see bone forming, osteophytes forming. So this is an example, a classic example of Cox arthrosis. So next case, again, here are also this joint looks relatively good, but there are some subtle signs like this being a little bit more dense than it should be, but this joint is relatively good. But here we see a severe Cox arthrosis with osteophytes forming, with joint space narrowing, and so on. So also a case of the same thing, joint space narrowing, osteophytes. So in this case it is the same thing. We see how the joint space is narrowed, how the joint is actually this is also severe Cox arthrosis. So what is done in those cases? So if the Cox arthrosis is like this, so very severe, where there is no other option, this can't be treated any other way than surgically. And one of the main options is a total prosthesis. So this is a built-in artificial ball and socket joint that is actually the joint that has been destroyed over the years is taken out, and the new joint is built in with a femoral component, a stem, an acetabular component, and a head, and there is also a plastic layer in this head. So this is also a severe coxarthrosis. We see this example, the joint narrowing, the subchondral bone cysts forming, osteophyte formations, and obviously this also needs to be treated. The only way is surgically by implantation of a prosthesis. And this is the implanted prosthesis. And with these prostheses, patients can actually have very good functional results and can have a very an excellent return to a normal life.
So before we see the x-rays for the osteoarthritis of the knee, the same here is the same. It is the same story as in hip osteoarthritis. So tear and wear, or wear and tear osteoarthritis. Over the years, using our knees, using our hips, being obese, mechanical trauma, and so on, fractures, predispose the bone, or simply aging because the cartilage amount isn't indefinite. It rubs and rubs, and over the years, it will, someone is more predisposed, someone less, depending how good how good the biomechanic is, how thick the cartilage is. Someone will develop osteoarthritis earlier, someone later. But in the end, it is the same story as with hip osteoarthritis. We will see cartilage damage, joint space narrowing, or then later osteophyte formation, eburnated bone or dense subchondral cartilage, and bone cyst formation. We can see all of these features also in the knee joint. So here to say a little bit about therapy. First, once we have seen that there is osteoarthritis developing, depending on where we catch it, what stage it is, there are different possibilities, but basically orthopedic doctors, orthopedic surgeons always try to, when they can, when it is possible, to treat it conservatively. Once, of course, if the patient comes and there is severe osteoarthritis that cannot be treated conservatively, when only surgery is an option, they will go for surgery. But there is basically, every patient is different, and every patient will require a different approach depending on the clinical picture and on their status. Thank you.
So now some X-ray examples of osteoarthrosis in the knee joint, which is also very common. We can see the things we already explained. This is obvious that here is joint space narrowing. So, and subchondral bone density is increased. So, and also the lateral X-ray, we can see osteophyte formations. So this is gonarthrosis or osteoarthritis of the knee, which this is a severe case where we need a surgical repair, or better to say a prosthesis to be implanted. There are many examples. This is one of them, an AP view of a left knee, we can see osteophytes, we can see joint space narrowing. This is a very nice picture with where you can see very easy these osteophyte formations. The same thing, only lateral view. Then another example, joint space narrowing, osteophyte formations. Also very nice view of this subchondral bone density increase, or eburnated bone as they say, like ivory. And now we will see a picture. So this is the same patient, the left leg and the right leg. We see already that a prosthesis, so the knee prosthesis has three parts: the tibial part, the femur part, and there is also an insert that is basically plastic that is inserted here between them. It is not dense enough to be seen on radiographs. We can see that this patient already has one prosthesis implanted, but because of these changes, joint space narrowing, osteophyte, subchondral bone sclerosis, this patient will definitely need also this need to be operated. And sometimes you can see patients that had 4 operations, so they operated both of their knees and both of their hips, so they have 4 prostheses. In those cases, the functional outcomes are not that great, but sometimes patients, we get often patients who get 2 prostheses in the knees or in 2 prostheses in the hips. So basically, it's the same story as any osteoarthritis, no matter is it hip or knee. These are easily to catch if they are this far progressed with this joint space narrowing. Even an untrained eye can identify this as pathology. Thank you.